Hello everyone, welcome back to Desert Docs, a junior doctor's guide to Central Australia. My name is Dr. Indi and today I'll be talking to Dr. Dan Adams, Director of the Central Australian Retrieval Service and Fellow of Emergency Medicine, currently working at Alice Springs Hospital, and Rex Neindorf, Director of Alice Springs Reptile Centre. Welcome.
Welcome.
Thank you very much, Indi.
Firstly, I would like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Aranda people of Mantua. We recognise their custodianship and their continuing relationship with country, and that we work on their stolen lands. So let's get straight into it. The Toxicology podcast for today. We'll be asking questions from a junior doctor perspective. I've done a rotation in ED and not yet seen and managed a snake bite, although I do know they're out there and they're increased over summer. So let's start by introducing the types of snakes we see in Central Australia.
So the main snakes we catch, which is here in Alice Springs, which is the same basically across all of Central Australia, is you're looking at the western brown snake. So it's a very, very common snake in Alice Springs. Then you've got things like your desert whip snakes. So desert whip snakes are a mildly venomous snake, whereas the western brown snake is a highly venomous snake. Then we have eastern brown snakes here as well, which is technically the second most venomous snake on the planet. But even though they're here, they're rare compared to westerns. Westerns are like every second house has a western. And then you have mulga snakes, which are also highly venomous. But the problem is their name is king brown as well. We don't like that name, so we prefer the name mulga snake because they're a black snake. So you would need black snake antivenom if they were envenomated. And there are death adders close to town, but not necessarily in town. And then, of course, we have curl snakes, which are really, really common in town, which are mildly venomous, and a few other mildly venomous ones around. But by far and away, western brown snakes are number one in town, and then your desert whip snake would be number two.
Yep. And Rex and I were having a bit of a chat before we came on the microphones about how the snake bites present. And Dan, I'm sure you've seen quite a few of these as well. But Rex, you were getting out the fangs of different snakes, one from overseas and one from Central Australia. And the difference is between 4 centimetres and 2 millimetres, being that the local snakes definitely have a smaller fang and a different presentation to what we traditionally think of as a snake bite. So can you talk a little bit more on that as well?
There's a few issues that always crop up. So the main thing is that when we see things on social media and you get all these memes going around at the start of snake season about what a snake bite looks like, how to tell a venomous snake from a non-venomous snake, most of those things are completely untrue. So we try to get people to not do that Google and look at things on memes. It really doesn't work out. And when we get people coming from overseas, a snake bite overseas looks serious. You know, you'll see 2 big puncture marks, you'll see swelling, bruising, lots of pain, bleeding, all sorts of those sort of things. Whereas in Australia, the worst bite is probably like a brown snake bite, which is like a little tiny scratch to the skin. And when it happens, unless you see it happen, so if you're walking through long grass with bare legs and you get a little scratch, and you feel a scratch, but that's all it feels like, and then there's nothing further. And then you come out and you look at it, and it's a little scratch. There's no bleeding, there's no pain, so you just keep walking. And that could probably be the worst bite you'll ever see. And then very shortly after, if you kept walking, it would turn quite nasty. But the thing is, a snake bite overseas looks painful, it looks bad, whereas a serious bite from a brown snake looks like nothing. So there's no tiger snakes in Northern Territory, there's no red belly black snakes, there's no copperheads. Those sort of things don't exist in Northern Territory. So in Alice Springs specifically, in our region here, you've got western brown snakes mainly, the odd eastern brown, and then you've got mulga snakes. So a mulga snake bite is going to look like a bite. They've got slightly bigger fangs, they've got a bigger venom yield, they have a myotoxic venom, so it affects muscle tissue, so it hurts when they bite you. So if they inject venom, it'll present as what a classic bite looks like, whereas a brown snake presents like a scratch.
Sometimes with a weird early collapse, and then they kind of get up and they feel all right. And then they go, oh, that wasn't much, was it? Famously, a pair of socks is a not the best protection, but it's often enough protection to stop yourself from getting injured by a brown snake. And certainly any old pair of pants, as opposed to many places around the world where you've got to have thick, tall boots.
That's a good point, and it's not just real thick boots. It's also people overseas commonly wear gaiters, and they have those, and you need them overseas because you got fangs, like 3 centimetres long, 4 centimetres long. Whereas in Australia, when you've got fangs between, say, 1 to 3 mil long, as the average is about 3 mil. So you're looking at most snakes in Australia, be they tiger snakes, black snakes or brown snakes, which are the 3 common highly venomous snakes that we're going to come across. And talking about pants, those loose-fitting pants are actually quite good because they hang away from the leg. It gives you a really good degree of protection here in Australia. It's the same as when people go gardening, and if you wear long sleeves with gardening gloves, it gives excellent protection, which wouldn't happen overseas.
Rex, you've given us a bit of an overview of the species and a bit of an intro into the different types of toxidromes that they might cause. Dan, can you speak to the other kind of toxidromes and whether when you receive a snakebite call through retrieval or in ED, whether it matters what snake has bitten the patient or whether you just kind of work off clinical signs and symptoms and you kind of work out the identity later?
Yeah, no problem. The truth is it does matter a lot what kind of snake has bitten the patient, but you rarely know. Usually they've been bitten and the snake slithered off. Out in the field or in the ED, there's often going to be a delay to identifying that snake. So you sort of work on the presumption this is an unknown snake. Let's go through. You still look for evidence of the 3 major toxidromes that you'll see, and they are a coagulopathy, myotoxicity, and neurotoxicity. And there are a couple of different sorts of coagulopathy that we see, and the 2 big snakes that cause problems around here are the mulga and the brown snake, as Rex has said. And they both cause coagulopathy, but one is a venom-induced consumptive coagulopathy, which is kind of clinically a lot like having a massive warfarin overdose, versus the anticoagulant toxicity, which is a little bit more like having an oxyparin overdose. But overall, your brown snake coagulopathy is more likely to cause big problems for you in terms of one of those catastrophic intracranial bleeds or GI bleeds or intra-abdominal bleeds. I guess we're looking for all 3 of those, and the first one that you're likely to identify is some early bruising and bloody ooze, perhaps specifically from the wound site. And then in terms of myotoxicity, the first thing that you might hear from the patient is that they've got generalised muscle aches, which is often compounded by, and we haven't talked about it yet, but by the overtight pressure bandage that they've had on that leg. And then the rarest one definitely in our catchment, but the most dangerous one for clinicians is the neurotoxicity that comes on often later, 12 hours plus later, and it's a descending paralysis. And so the first thing you'll find is that the patient maybe feels that their vision's being affected. They've got some double vision and they get a ptosis. And you've really got to specifically look for that, especially in children. They won't report it. They'll go home, it'll progress, and in the end, their diaphragm will stop working, and that's how they die. So that's the one that we really need to look out for. Fortunately, very rare in Central Australia. There have been issues in other parts of the country where, and in the top end as well, where patients have been caught out by delayed neurotoxicity. But around here, really, it's just that the only one really that can cause that is the death adder.
So you've landed in Yulara and someone's got a query snake bite. What are the really important history questions and also examination findings, and then later on investigations?
So this is a really common presentation, and the vast majority of patients who worry they've been bitten by a snake haven't been bitten by a snake. And so we often sort of throw around, was it a snake bite, was it a stick bite? And most of them are stick bites, and they've been walking along, they've stepped on a stick that's flicked up and whacked them, and it's a bit concerning. And you still need to take that seriously because you just don't know. And in the absence of any testing and further information, if someone thinks they might have been bitten by a snake, you've kind of got to err on the side of caution. But in terms of my overall concern for the person, if they say they saw the snake slither off or they saw the snake bite them, there's definitely a higher index of suspicion that they've been envenomed. So that's the first thing. If they've got the snake and they're out in the middle of nowhere, then and it's dead, then you'd be carefully taking some photos and potentially sending it through to Rex for identification. But that's pretty unusual. We don't actually get that very often. And then you'd be usually, initially, other than perhaps that story of initial collapse and then getting up again, the patient doesn't have much to say about it. The patient might have a little bit of localised bite pain, but that's it. The other symptoms start coming on later. But at that point, you're going to be starting treatment for this person, and the treatment is to stop them from moving. So it's a pressure immobilisation bandage. And one of the things that a lot of people forget about a pressure immobilisation bandage is immobilisation. You're immobilising the whole person. So if they've been bitten on the hand, it's not enough to pop them in the compression bandage and then let them kind of get back on and carry on with their marathon or whatever it is that they're doing.
Rex is laughing over there.
They need to
he's got a few stories to share
they need
there.
to be laid down and, stretcher transfers, and you're trying to reduce lymphatic flow, right? That's the purpose of this. And if they're contracting those muscles in that limb, then that's going to overcome the pressure bandage to some extent each time. And particularly if they're remote, as is the scenario you've just given me, you're trying to make this pressure bandage last a lot longer than there's any evidence for its use. As far as I understand, there's evidence for the use of a pressure bandage for up to about 90 minutes. And most of these patients need more than 4 hours to get into hospital to get their first set of blood tests and then to have it taken off. So we're really pushing it beyond the evidence base anyway, and having them lie still is an important part of achieving that.
Is the 90 minutes because that's when your body will have decomposed the venom anyway? What kind of initiates the removal of the pressure mobilisation bandage?
Right. So the 90 minutes is just because there are so few people in the world who are so far from a hospital that we don't have any science to back it up, right? There's not that. It's a tiny subset of people who get bitten by a snake and then haven't had a blood test in that time frame. So we just have uniquely remote patients here in Central Australia. The venom still will be floating around for a lot longer than 90 minutes if you haven't had your anti-venom. So it's certainly not that. In the hospital, once they get here, what we do, if they're asymptomatic, and look, if they're asymptomatic and it's been many, many hours, then for some patients, particularly if they don't have a great story for it, I will just say, look, wow, you're clearly in a lot of agony from that over-tight pressure bandage. It's been 6 hours. You have no symptoms of a snake bite. Let's just take it off so that you're comfortable, and we'll send the bloods off and we'll do what we need to do. But for the majority of patients, you'll keep them in the department, leave the bandage on, and you will do your standard blood tests. Once they come back and they're okay, then you take the bandage off while you're watching them, wait an hour, do some more tests and see what happens. So it's really just about... The idea is you pause time for the venom not to hit the systemic circulation until the bandage comes off, and then and before the bandage comes off, you test to make sure that it has worked, and then an hour later you recheck to see if they've suddenly got an INR that's unrecordably high or whatever it is. Yeah. But probably the worst thing about an overtight bandage is that it then muddies the waters in terms of your treatment, and when you get to the hospital and you start doing your testing. If you've had a tight pressure bandage on for 4 or 5 hours and then you take it off, then all of a sudden your CK, when you test it, is in the thousands or sometimes tens of thousands. And CK is one of the things we look for, evidence of mytoxicity. And in fact, in our guideline in the hospital, it says if it's over 1,000, then you've got to seriously think about whether or not the person's been bitten by a mulga snake. So we're stuck, right? And you've got to say, well, is this CK from the bandage or is this CK from the snake? And do I treat now, or do I hold off a little longer and see what happens at the 6 hour mark? And do we have a significant increase yet again? It has really significant downstream impacts on the patient's care if your pressure bandage is too tight.
Yep.
We conducted a bandaging study many years ago, and that was up at Darwin under Bart Curry. And in that bandaging study, we found out that a lot of people did a bandage either way too loose or way too tight. It was most people couldn't actually put a bandage on to the correct tension.
Sounds like estimating blood loss. No one can do it right.
And it was really hard. So, back then, these are the sort of bandages that were in use, and that's why we sort of use these sort of bandages now. And it sort of gives us a better degree of how to do a correct bandage compared to just guesswork.
And just for interest, everybody pulled out the smart bandage. They've got a rectangle on them, and if you pull them to the correct tension, the rectangle turns into a square. And there are a few other models that I've seen ones where if you pull the tension right, then there's two lines that line up. But smart bandages are the ones that I tend to see around here, probably because Rex sells them.
I want to get stuck into these bloods that we need to order because I think they're very well explained in the guideline. If anyone working at Alice Springs Hospital wants to look them up, they're very detailed. But just to kind of explain them for the purposes of the podcast, if no one's got a computer right in front of them, we've got a standard set of bloods that look for that coagulopathy, that myotoxicity and neurotoxicity. And they're the same, I understand, the same bloods at every interval. So the bloods that are done at time 0 and then time 1 hour and then 6 and 12 hours. And those, Dan, I might hand over to you to kind of explain
to talk
those.
about them. Yeah, no problem. Yeah, so I was the one who came up with the list of things that we test for. And, there's a little bit of controversy about what you might and might not test for. And if you look around the country, you'll find different places suggest different tests. But for us, we want a relatively extended coagulation panel, which includes a D-dimer and an INR and an APTT and a fibrinogen. We want an FBE, which mostly is looking for your hemoglobin, and sometimes, incidentally, you will also find a white cell count that's quite elevated. And then your renal function is really important, and your potassium for someone who is having significant rhabdomyolysis. And then you've...
Creatinine.
And creatinine as well for renal failure from rhabdo as well, and the associated renal failure. And then we're doing your creatinine kinase, which looks, again, for rhabdomyolysis. And then LDH is a general marker of cell breakdown. And then your LFTs as well, which is probably the least useful of all of those tests there. Yeah.
Yep. And a urinalysis as well.
So urinalysis can be useful early, and one of the things about a urinalysis is it's a test that can be done pre-hospitally. If you're sitting in a clinic for a little while, you can get a urine, and if you see blood in your urinalysis, then that's actually myoglobin probably being picked up on that same strip. So you're really testing for myoglobinuria, which is a sign of a raised CK.
Yeah. Which could be the pressure bandage.
Which could be the pressure bandage, yeah. But if you're seeing it pre-hospitally within a couple of hours, it's more likely to be something to do with a snake.
Yeah. So you've done these bloods. You're thinking about taking the pressure bandage off at somewhere between the time 0 and time 1 hour, or after the 1 hour?
So as soon as your bloods are back, if they're reassuring, then take the bandage off. We're trying to get to the point that we can take this bandage off as soon as possible, and just because it's an uncomfortable thing, and as I said, it can muddy the waters if the bandage is on a bit too tight. So as soon as the blood tests are back, then you'll take the bandage off, and then you've got to give it a little bit of time to see what happens. You don't want to immediately test for all of the same things again, because although sometimes you can see a bolus of venom hit the system, more commonly it'll come in slowly over the next sort of half an hour to an hour, and that's the time that you want to repeat the tests and see what you find.
Yep. And so if you've repeated those tests, so say you've taken off the bandage at 30 minutes after your time 0 bloods, and the next bloods would be 30 minutes to an hour after that, and then do you space it out to 6 hours as your third bloods?
Yes.
Yeah.
So once you've done your post-removal bloods, you wait 6 hours after them to do the next lot. Yeah.
Okay.
And you really, and one of the things in our guideline that I think is not entirely obvious is that it's from the time of the bite as well. Like if you've taken 8 hours to get to hospital, as may be the case, then you don't need to come in, start at the 0 hour mark, do your first set of bloods, do your post-bandage removal set of bloods, do a 6 hour set of bloods, do a 12 hour set of bloods, because they're already well into the whole thing, right? So if you're 8 hours in and you rock up, the idea is you would do some immediate bloods, if it's that delayed, I may seriously just consider taking off the bandage anyway. But I'd do some initial bloods, take my bandage off when it's normal, repeat again an hour after that, and then I would probably do one lot at 6 hours after that and make sure that they're still okay, and then I'd let them go. Right, because we're talking about a patient who is 15 to 16 hours after their bite and still totally asymptomatic. And in Central Australia, that's long enough. If you're in a place where you're more likely to have a neurotoxic bite, then you might do a 24-hour blood test. And in fact, if you look on our internal guidelines and you look at the top-end guidelines, they say to do 24-hour bloods because they have had issues with, I think it was a death that occurred up there some years ago after some normal tests done at the 12-hour mark. I don't know if you know anything about that, Rex. It was before my time.
It might have been death. There was also a sea snake bite.
I remember they hit the news, a sea snake bite. That one didn't even hit the hospital, though. I think they were dead on the water still. Yeah. Which is awful. So sea snakes can cause an absolutely catastrophic rapid rhabdomyolysis, and that's what caused that death.
Yeah, Rex, we were talking earlier off mic about neurotoxicity being a late sign that you were saying the patient was discharged before the late neurotoxicity was coming on, and that's happened more frequently in the top end. Can you speak a little bit more about those circumstances?
The common ones probably in Australia are tiger snakes. So you've got presynaptic and postsynaptic neurotoxins. And so that's why they generally keep people in, for a little bit longer, just in case. So, but I've got a couple of stats here just on snake bites. So between 2000 and 2016, we had 35 deaths in Australia with snake bite. So that came out of the snake bite report that was compiled. And then Royal Darwin has approximately 50 snake bite presentations annually. In Northern Territory, we've had 6 deaths over that 20 years. 4 were brown snakes, 1 was a sea snake, and 1 was still under investigation now as to which type of snake. And then, of course, the brown snake deaths, which has been 4, 1 of those was in Central Australia, and 3 were northern browns in the top end. So you're looking at brown snakes, which are strongly neurotoxic as well. But then, of course, you have your coagulant. And the coagulant in brown snakes is a pretty effective one.
Something we haven't talked about yet, which is the antivenom. I was reading the guideline, Dan, and it said that you can swab the bite to identify the snake, or you can use Rex's experience and high-quality photos sent by yourself, Dan, to identify and then do the antivenom.
And it can be pretty challenging for Rex, given all the interbreeding that occurs. So you've got a couple of ways to identify the snake. Practically, most of the time, we've just got to say, we're not sure what this is, and this person's clearly suffering from an envenoming.
Clinically or biochemically?
Clinically or biochemically, let's give them polyvalent antivenom. Now, if you can, you'll avoid polyvalent. It's got a really significant risk of anaphylaxis and also serum sickness and so on, quoted at 40%. Now, I've seen it given enough times that I've seen anaphylaxis, but it certainly hasn't been at the 40% mark of the patients that I've been around when it's been given, but it is significant. And it's high enough that if you can give 2 monovalents, if you're confident that it's one of 2 specific snake types and you can give 2 monovalents, each of them has a kind of 10 to 15% chance of anaphylaxis, that it's probably less risk for the patient to choose to give, say, a black snake and a brown snake antivenom than a polyvalent antivenom if you've got the capacity to do that.
The way we make antivenoms in Australia is that there's actually no complete monovalent antivenom in Australia. So because the horses that we use, they have little bits of all of the antigens or all the antibodies in them. And so when you get antivenom, in there's also bits of brown death adder, taipan, tiger that's actually in that antivenom. So it is interesting that it's almost like a little mini polyvalent in that actual bottle, whereas you look at the antivenoms coming out of Costa Rica, they actually make a pure monovalent antivenom, whereas in Australia it's actually not. So you're actually getting a tiny little bit of a polyvalent antivenom in you, but it's the horse serum that causes the issue.
Yeah.
And in poly, you're getting more of the horse serum.
It's a bigger vial.
Than what you're getting in the mono. So that's where the issue arises. But having said that, if you look at antivenoms now compared to what they used to be 50 years ago, they're much purer than what they used to be. So that's one good thing. And also, they're managed better. And that's the key to it, is the setting in which a snake bite is managed now is a lot better than what it was 50 years ago. So
With tourniquets.
That's right. Yeah.
but you
Well-trained junior doctors.
That's it's really what it boils down to, is the setting. In the ED setting, it's a hell of a lot better than what it used to be.
And to come back to the SVDK, so we do a snake bite venom detection kit.
Yeah.
And they do have them at the lab here in Alice Springs. Swabbing the bite site is the best way to get a high yield SVDK.
Yes.
If someone's washed the bite site already, then you're out of luck there. And the next best test is urine. So you take some urine and do it. And people make the mistake of using blood, but you're more likely to get false positives and the wrong well turning positive first if you use blood. So it's skin, then urine, then blood.
Yes, that'd be correct.
Another important tip here is that, and one of the reasons why we've got the extended panel there, is that if you send some blood off, and as so many of us do, we don't put any clinical details on it, then what the lab will do is they'll sit there and they'll process that INR, and they won't report it back to you until the test is finished. Yeah, and it's a test where for the time it takes for the blood to clot, and if the blood never clots, then they'll not report it to you for a long time.
Yeah.
So always write that it's for a snake bite, and if you haven't got a result back in a reasonable time frame, just call the lab to check.
Yeah.
But I've also seen patients who have still got a relatively normal INR, in 1.6 or 1.7, and then their D-dimer's way off, or their fibrinogen's starting to go off as well, and so those can be useful. And of course, they'll go back and they'll test those numbers if you do get a proper envenoming on the original bloods, even if they weren't done. And so I've also seen that there is, when you've got an envenoming, those tests are useful, not just the INR, not just the APTT.
Are there any other tips for young players that you would recommend before we move on to a small couple of questions about spider bites?
Yeah, look, we talked a little bit about what the bites look like and what your differentials are before we were actually recording. And I think it's important to recognise that those classic two little dots, a couple centimetre or 1 to 2 centimetres apart, are less likely to be a dangerous snake bite and more likely to be an insect bite, a centipede, or perhaps a spider. And they're the ones that people come in and they've got this painful, obvious bite, and of course, if we don't know what it is, we will err on the side of caution. But I'd bet my bottom dollar pretty well every time that we're going to come back 12 hours from now and we're going to have some normal bloods, and we'll be giving the patient a pat on the back and let them go home.
We'll just talk a little bit quickly about spider bites, just to round up the Toxicology podcast for today. So I have seen a spider bite in ED, identified by the patient as a red back spider. In my brief research, I learnt that no spiders can cause death in Central Australia. Is that right, Dan?
Well, look, if you had a nasty envenoming from a redback spider and you were a super complicated medical patient with a known ischemic heart disease and underlying heart failure and so on, and then the additional stress of that might cause a problem. But basically, you're right, that redbacks are the most dangerous spiders that we have in Central Australia, and they're unlikely to cause death.
Yep. Will present with pain, bit of swelling, bit of erythema.
Yeah, they can get hypertension and a general lacrodectalism, so they can get systemic symptoms and significant discomfort from systemic symptoms, but it's unlikely that it's going to cause death.
Yeah, and I read getting worse over a couple of days with then lymphadenopathy, and you just send them home with analgesia. So
there's controversy about what you do, and the best evidence that we have, it comes from the RAVE2 trial. They looked at the clinical benefit of giving redback antivenom, and it showed there was really no benefit in giving redback antivenom, and it really has changed, I think, the way people all around Australia treat redback bites. But anecdotally, individually, I think most emergency physicians will have had an experience where they've given the redback antivenom and they've seen a significant improvement. And I do think there is still a place for redback antivenom, and I accept that this is a slightly controversial comment, but we have it still in the hospital. We do give it from time to time, and the people that you give it to are those people who have not had sufficient symptomatic improvement from the opiates and basic analgesics that they've been given, and they come back once or twice, they're still sweaty, they're still hypertensive, they've still got serious aches all over their bodies, and they haven't been able to sleep, let's give this a go. And we know that there's a bit of a risk of anaphylaxis and serum sickness from giving the redback antivenom as well, but for someone like that, you ask them if they're willing to take that risk, and they will furiously nod. So, that's the sort of person that you might still give redback antivenom to. Weirdly, I think I was looking at the stocks in Adelaide here and Darwin for these things, and Alice Springs seems like the hub of redback antivenom. We've got like 36 vials of the stuff.
Oh, wow.
Maybe we just use it less.
That's crazy.
Yeah. But we also have an absolute bucket load of redbacks in this town.
Yeah.
I mean, people do
is,
get bitten by redbacks quite frequently here.
Yeah. And you were talking about white-tailed spiders, Rex.
It looks like it's bacteria associated with the bite and not the venom that causes that. So those people have had necrotic effects, and the venom was blamed. It looks like it's not the venom whatsoever. So it looks like bacteria that's then associated with the spider that gets into the wound. But that's the other thing about wound management, is keeping the wound clean, looking after that wound, and that's probably one of the, especially if you're out bush, that's one of the big things. You got to remember that in Central Australia we're quite lucky because we're not in the tropics. Where the tropics things can go south really quickly.
They're wet. They get wet and manky.
Yeah. So we're fairly lucky here like that we do have an arid interior, so that's not too bad. Tropics is a little bit more concerning, so we're okay there.
And I haven't had a look at the data in a while, but when I last had a look at it, there actually hasn't ever been a definite white-tipped spider bite that has caused necrotizing fasciitis or these wounds that you see images of are not from confirmed white-tailed spider bites. They're from reported white-tailed spider bites. And there was a study done where they looked at dozens of confirmed white-tailed spider bites, and none of them had any significant problems. So it's I think a spurious link there. And then the other one, and that was a bit of a surprise for me, was what was the spider?
Mouse spider.
The mouse spider.
So mouse spiders are right across Australia. So, they're pretty well everywhere. So that one's the red-headed species, which is the male. So they've got a bright red head, blue abdomen. Then you've got the female, which is like a big heavy-duty black thing, which basically never leaves its burrow. So, but mouse spiders are a significantly, venomous spider. So they're not in the realm of funnel web, but they're two megalomorphs. They're the old world spiders. They're the ones that rear back and strike down. So you look at funnel webs and those, and funnel webs are particularly basically mainly on the east coast of Australia, mainly in Queensland, mainly in New South Wales. And then you look at the mouse spider, which is widespread. And it's interesting that the state that has the most mouse spiders now is Western Australia. So Western Australia has a whole stack of species of mouse spiders. But the mouse spider, there hasn't been that many records of bites, but their venom's pretty up there. So that is one thing you're going to have to be pretty careful of here, because there's a lot of mouse spiders here.
Yeah, I don't remember ever having a case where we thought that was on the list of possibilities. Or
I can't remember one here either. Yeah. Certainly there's been quite a few redbacks here, as in bites.
Yeah.
Over the years, there's been quite a few. But and the other thing we commonly see here, more than anything else, is centipedes. Yeah. So we don't see that many scorpions, as in, people stung by a scorpion, but we do see people that have, in my opinion, have been bitten by a centipede.
Yep.
So, but you look at centipedes; they could go pretty well everywhere, and they'll climb up the inside of a trouser leg. So, because they're on the inside of the leg, and you don't know they're there till you stand up or move, and then bang. So, and we get so many questions about people who go out camping, and they say, "Oh, does a snake get into someone's swag?" And that hardly ever happens, but it's really, really, really rare. What gets into swags is your things like your centipedes, scorpions, spiders, ants, all those things get into swags, get into people's shoes, get into all those, everything else. Snakes, it's very rare to happen. So I tell people that, when you go out camping, don't just set up your camp and roll your swag out, you should keep your swag rolled up. And the other big thing is shoes, just basic things like shoes, where people kick their shoe off, the shoe falls to the side. If you get a centipede into a shoe, and even if you pick the shoe up and you give it a thump, it won't dislodge it.
They got 100 legs, did you know that?
So, yeah, did you count them all? But a simple basic thing just to protect shoes is just get your sock and turn over the top of the shoe. Just really basic things like that. It's all about prevention rather than cure.
Defensive camping.
I think we've talked very thoroughly about snake bites and spider bites. Thank you, Rex and Dan, for coming on the podcast. It's been great to have both perspectives from the emergency and community management. Thanks again, and that's another episode of Desert Docs.
Thank you very much.
Thank you very much, Indi.
Desert Docs, a junior doctor's guide to Central Australia, is an NT Health Media podcast produced with the help of ACCC Studio.